Thank you for joining us today. My name is Laura Polis, and I'm a healthcare communications consultant that helps the Missouri Health IT Assistance Center at the University of Missouri. Today's presenter is Diana Jones. She's the program manager for the Missouri EHR Incentive Payment Program. So without further ado, I will let Diana Jones take it from here.
Thank you, Laura. Good morning, everyone, and thanks for joining us. As we anticipate the opening of the state-level registry next month, we wanted to have an opportunity to review with you the changes for program year 15 and go over the requirements. And similar to the December meeting, if you were able to join us then, we're going to just review the basics and clarify or review again the required attachments. I also have a couple of updates of information that's come out since December. The program changes that we're going to review are the same changes that we reviewed in December. I've outlined here the documents that are going to be required in the SLR as you go through and submit attestations. Most of those have been required in past years and will be again. And then there are a couple of new ones for the meaningful use in the meaningful use section. And then, of course, we'll review the dates that we expect to be open. And I've got a few slides with some additional resources, and then we'll have questions. So the first thing that I want to review is just this is a clarification. In January, there was a lot of publicity around some comments that were made by Andy Slavitt, acting administrator at CMS. And the coverage of those comments, the interpretation, resulted in some headlines that suggested that meaningful use is ending and the incentive program is ending. And lots of clarifications have been issued by CMS and others. The program is still very much in effect. Those comments were regarding direction that CMS is taking as their program does have a different timeline, and they're looking toward the future at how they might align the EHR incentives and meaningful use with other programs, other incentive programs. So just to review, the authorizing legislation for the Medicaid program runs through the year 2021 for Medicare. It was a shorter span from the very beginning. So program year 2016 is the last year that program was initially authorized. And then the deadlines, Medicare attestations in the CMS system are being accepted for program year 15 now through March 11th. They just extended that deadline from the end of February through March 11th. For our Medicaid system, as you know, we're expecting to be open mid-April and through the end of June, and we will announce exact dates for opening as we get closer. We still we'll be working on our user testing, so we'll have a more certain idea soon, but at this moment, we're looking at the middle of April. There are a couple of options for people for program year 2015 that I want to mention and have had some coverage and announcements from CMS. One is the alternate attestation method, and this CMS put into effect for eligible professionals who have participated in the Medicaid program in the past but will be unable to in 2015 based on not being able to meet the 30% Medicaid patient volume. If that is true for any of your providers or any of you listening, the option that you have in order to avoid the Medicare penalty, which is a payment reduction on Medicare payments, is to go into the CMS system and provide your meaningful use data using their system. And then they will, then in that way, the EP would avoid any penalty. Now, of course, to do that, you have to do that when the CMS system is open, which is now between now and March 11th. So that's a new option that is really related specifically to those who cannot meet the Medicaid patient volume threshold. Then there is another option called a hardship exception. And this year, CMS has streamlined that process. That actually involves submitting an application. The application form lists a variety of reasons that one might apply to Medicare for a hardship exception, but there are a couple specifically that refer to issues around implementing certified EHRs and vendor issues. So if that is something that has affected you and you're not able to, you won't be able to attest in 2015 because of that, that's an option. And again, the deadline for that has also been recently extended, and so that is available now through the end of July. Okay, so that's kind of the news since last we talked. Here is the summary of changes that affect program year 2015. First of all, everyone that's attesting to meaningful use will have a 90-day EHR reporting period. No matter what stage, no matter what year, you just have to do 90 days for program year 2015. CMS also aligned the program years for hospitals and professionals. So hospitals who were previously on federal fiscal year will now be on calendar year. There's no requirement for updated certification, new editions of certification this year. So everyone would be expected to be using a 2014 edition. That, of course, means you're using your 2014 edition to produce your 2015 reports. And then a basic concept is that everyone is in what is called modified stage 2. That's true for 2015, 2016, and 2017 until we reach 2018, at which point everybody will be in stage 3. But right now, everyone's in modified stage 2. There's one set of objectives that replace the core and menu, so there's 10 for EPs, 9 for hospitals. The way that the year of attestation is important is it affects the number of objectives, alternate objectives and exclusions. So for those who would have been in stage 1, there will be additional options available. And then there are some important changes specifically to the public health reporting, and we're going to go over those in a little bit more detail. And CQMs is a point of constant, so there are no changes to that. Reporting continues as in the past. So the next slide just outlines the objectives and measures that are in effect. Those are the 10. You see the for EPs, and the secure messaging does not apply to hospitals. If you haven't already done this, there's a tip sheet with specifications outlined for each of these measures CMS publishes on their EHR incentive program webpage. Those are very helpful. It gives you the details for each measure and whether there is an exclusion, and if there are, what those are like. So you can get a really good idea what you would need to, what kind of information and what kind of thresholds there are, if any. For the stage for program year 2015, this is the way you can tell ahead of time what your professional, what stage, what options will be available to them. So if you have an EP that has not yet attested 2 years, not previously attested 2 years to meaningful use, they will be, and they would have been in stage 1. So if you had attested last year to AIU, but you've never attested to meaningful use, you would have been in stage 1. If you attested to AIU and meaningful use 1 year, again, you would have been in stage 1 because this would be your second year in stage 1. For stage 2, if you've attested to AIU and 2 previous years to meaningful use, then you will be in stage 2. And the state level registry will determine the stage of each provider based on previous attestations. So when you enter the system, it will populate with the options that are available to you based on this formula above, whether you would have been in stage 1 or you would have been in stage 2. And the reason that is important is those who would have been in stage 1 have additional alternate exclusions and sometimes even alternate measures that are available to them. As far as required attachments, as you know, most of you, if you've been into the system before, for AIU, we have a number of required attachments, and this is the list. For in step 2, everyone has to attach what we refer to as the DCN report. DCN stands for Department Client Number. That's the unique number assigned to Medicaid participants and others who are receiving services in the state. And if you need any additional descriptive information, we have a handout that we can give that gives examples of that. When you reach stage 3, everyone has to provide either the contract or a vendor letter that supports their use of the certified technology. And in step 4, we require several pieces of information in order to execute the electronic payment. We have a direct deposit form, and we require some form of federal document to confirm that the payee information is that's given to us is the legal payee information, so that our 1099s are produced with accurate information. And then finally, a signed attestation, which is generated in the system that summarizes all the information provided. In addition to this, if you're attesting to meaningful use, you have to provide all the information that you would on the AIU list. And in addition, we have 2 new requirements this year. The first one is the summary report from the certified system, from the 2014 certified system. So this would be a summary report for whatever 90-day period you're choosing in 2015 that you generate for each EP, and these are generated from the system. So each system has a way to do that, and many of you have been attaching that in the past because, of course, this is required if you are audited for meaningful use. So the best strategy is to produce it when you attest so that you have it if you're asked to provide it at a later date. Second, we're going to require evidence of the security risk assessment. The new name for this measure is Protect Patient Health Information. And so we're going to require an attachment there. And then in the past, we have requested and required attachments to support public health measures. So we're going to talk about what that's going to look like in the future, but essentially a letter from the Department of Health and Senior Services confirming active engagement or confirming that you need exclusions will be required. And Patty Osmond and Brenna Davidson are on the call today, and when we get to the descriptions and discussion of the public health measures and questions, they're going to be available to answer and give clarifications for any points of interest. So again, just a review of the measures. The blue highlighted ones are the ones that are going to be requested. I think it should be clinical data registry reporting on that last one. That's a typo. But those are the 3 that are going to require attachment. So let's just go through briefly each of those and talk about them. The first one is the Meaningful Use Summary Report of Objectives, which is outlined on the next slide. So you just essentially will follow the process that is appropriate for your EHR system to generate a meaningful use summary report for each provider that's going to be attesting. And that would be for the 90-day reporting period that you choose during calendar year 2015. So if you have any questions about how your product would produce that report, you should contact your vendor. And some people have asked us for examples, and we have a couple that we can give, but I think that's fairly self-explanatory. For the patient health information, protect patient health information, the objective is, in its full statement is copied here, to conduct or review the security risk analysis and implement any updates as necessary and correct any deficiencies. In addition, the analysis of potential risks and vulnerabilities would be described as a result of this. And this would be a comprehensive risk analysis. But once that is done, then in subsequent years, as described on the next page, you're required to take additional reasonable and appropriate steps to reduce the risk. So there are questionnaires and summaries. We're going to request evidence that you have done that. Either if it's your first year to do the analysis, we are going to require a summary of that, or if you are reviewing your analysis to determine and implement appropriate steps, then we're asking for that. And a big part of the reason that we are asking for this documentation is we have found that some people believe that they're not required to do this because their vendor takes care of security or some other reason, and don't discover until after the fact that actually there is no exclusion for this measure. I've included a couple of resources on the next, which can take you to a full analysis questionnaire, and the security risk tip sheet also has some links in it. And we have a summary format that we can also share. If I can find a link to that, I'll put that on the slide before they're posted. But get in touch with us if you have any questions about that. We're not dictating a specific format, we're just giving examples of what will be acceptable. So for public health reporting, the third required document, this is a summary of the new objective and measures as they are arrayed. And you can see there where all of the public health reporting is folded into one measure. And then there are some, specifically here, you can see a good example of how there are alternate specifications if you would have been in stage 1. So if you would have been in stage 1, you're only required to meet one measure. If you're in stage, you would have been in stage 2, you have to meet 2 of 3 measures. I think the easiest way to think about this for immunization syndromic surveillance, and in Missouri we have a cancer registry in effect. So those are the 3 that are in effect for EPs, and then the lab reporting for hospitals. The way that the measure has been restated is captured on the next few pages. So in order to meet this measure now, you have to show that you are actively engaged with the public health agency, and that engagement can be in any one or multiple forms. Everyone must be registered, and then you could also be testing or in production. And the definitions for registration are on the next page. If you have previously registered, you do not have to register again. One registration is sufficient. If in our system you're required, because of your choices, to offer proof of registration, then you can use the letter from previous years, or you can use the confirming email the documents, the automated generated email, the documents that you registered. If you have an additional letter from public health supporting that you are involved in testing or you're in production, that letter will also note the date of your registration. So you might be able to use that letter to support all the needed attachments in public health, depending on what your situation is. I think the next slide just reviews testing and validation, the terms of that you have to be, in order to be successful with that, you have to respond to any request from the public health agency within 30 days. And of course, this would be verified in your letter from public health. Production simply means that you have successfully completed the testing and you're submitting electronically to the public health agency in an ongoing way now. That is the way the public health measure has been summarized. Here's a few resources on public health. Obviously, the top one is just how to get in touch with the Department of Health and Senior Services by email, and there are lots of resources on the website. CMS has also released some new guidance and some clarification on their frequently asked questions. So I've cited here some of the numbers of those questions and with their topic, so that you can have some additional detail about how you can qualify for exclusions, what's the timing. Specialized registries, the main description there is that you're not required to do an exhaustive search of every potential registry, but the first check is with the state, and if the state has a registry, which in our case it's the cancer registry, and you qualify to report to that, that would be the first thing, or you may qualify to exclude. So that would be an important starting point. After that, you can check with any specialized registry if you're a hospital or an EP that you might have an affiliation with, and what action you take depends on what you find from that contact. But if you're a hospital and your specialist could potentially be involved with 6 or 10 professional societies, you don't have to check with all of them. You just have to check with at least one. Okay, so let's just talk again, review what we're doing. We're still working on the changes that have to be made in the system. So right now, if you've tried, you will notice that you can't actually do anything for program year 15 yet, and that's because the system isn't open. And our best estimate is mid-April, and I mean that literally probably around April 15th, unless we find something in user testing, the system will be open, and we will circulate the date as soon as we have it, and we have approval to keep that open through June 30th of 2016. So there'll be about a 75-day window. Hospitals is further out, and our estimate at this point is September 1 through the end of November, and again, specific dates will be announced but as we get closer. So I don't expect to know any more about the hospital dates until probably July or August. I'm going to mention for program year 2016, for those of you that are thinking ahead, we are planning to open for program year 2016 after we've closed program year 2015. So for professionals, that means that we won't be open until July or August for 2016. And we would hope that and expect that the program year for 2016 will resume a more normal kind of schedule. So, as in past years, we would have been open earlier for 2016. We would have a longer run for 2016, and the grace period would be at least 60 days into 2017. So I've just given you tentative dates of what we think we are looking at for the 2016 schedule. Probably the two most important points about 2016 are the last two. which is that this is the last year, 2016 will be the last year that you can begin to participate in the Medicaid EHR incentive program. If you haven't started in 2016, you can't start in 2017. If you have in 2016 or prior to, you can continue as you are able to. And the other thing that's important to note is that the reporting period for 2016 will be a full year. So that will make a lot of difference in terms of when you can submit your attestation as well. And we'll have to look at that as we think about the program year. In the last few slides, I just have collected some websites and contact information for resources both at CMS and locally. Probably many of you already know that CMS maintains and updates a web page specifically about the EHR incentive program. So if you wanted to take a look, you can get a very good summary of what is required for 2015. You can go in and look for the professionals in the hospitals, exactly what you're going to have to produce in terms of the meaningful use measures, and look at those tip sheets. As well, we in Missouri are fortunate to have a regional extension center, which is the Missouri HIT Assistance Center. That's a website listed there, and you can obviously send your questions in there, and they'll get forwarded to us if that's needed. They have several partner organizations that are very active with many of you, and those folks at the Primary Care Association, the Hospital Association, and Primaris particularly are often consulting with different providers and groups and in touch with us if they need clarification. So I encourage you to use that resource if it's available to you. And then I think the last slide, I have the contact information for our SLR help desk. And I know that many of you have already been in touch with some of these folks or whoever you normally work with. You can also send questions to the general number, but if there's someone on this list that you normally work with or have worked with in the past, feel free to reach out to them, and we will respond and consult as necessary to get you the answers that you need. So I think that's the end of the slides, Laura. I'll be happy to take questions, and I know our partners from Public Health are on, so they can chime in if it's a question related to that.
Absolutely, and thank you so much, Diana. We do have a few questions that folks have written in, so I'll start there. All right, the first question is, will we still have 90 days to complete attestations if the site does not become available until mid-April?
Right as of this point, we have not asked to extend the grace period or the period of time that we're open. We have to have approval from CMS. So right at this point, what we have is April 15th through June 30th as the open time frame. If we need to, we could extend that. I would prefer not to because of the things that we've discussed. The longer we delay that, the less that means a delay in opening for 2016. So we're going to remain open to that if we need to, but at this point, what we know is that it'll be open until June 30th. If I find that that April 15th day is going to move back very much, then we'll probably look at adjusting that.
Our next question is, hardship application form does not seem to be dynamic yet. Any idea when the application will be available in this format to submit electronically?
It is available. CMS has done a couple of announcements and updates, so if you get in touch with one of us, we can send it to you. It's out there.
Our next question, on the attachment for CERT, can we attach either a contract or vendor letter, or do we have to attach both?
The only reason that you would have to have an additional vendor letter is if the original contract either is for a system that initially was certified at 2011 and now we need to see evidence that you've got a 2014, or if the initial terms of the contract have expired and no longer in effect. So if you have a contract, if your current contract describes the certified system that you're using right now and it shows that it's in effect, then we wouldn't need a vendor letter. But if your initial contract that you submitted was updated, then you can give us a vendor letter just confirming the certified product and the signatures and the terms, the dates that's effective.
All right, our next question. What happens for EPs with no previous MU attestation experience, i.e. AIU levels EP?
So if you have an EP that had previously attested to AIU, this in their attesting in program year 15, they would have been in meaningful use stage 1. And therefore, all the alternate exclusions and alternate measures will be available to them in the system when you attest. So they have the widest range of options for the meaningful use measures.
Our next question, immunization registry question. Is anyone using the Allscripts professional EHR in production with the state immunization registry?
I can answer that one. This is Brenna Davidson. I am the Meaningful Use Coordinator for the Department of Health and Senior Services. I don't know off the top of my head if Allscripts is in production for immunizations yet on any sites, but I do know that they are a certified EHR. And just having them and being in active engagement with us will be enough to meet your meaningful use measures. As long as we are working on that interface, we won't hold it against you if your vendor isn't working out well on our end. So you should be covered as long as they are certified, which they are, and you register with us. If you don't know if you're registered or you don't know where you stand with us, just give me a call or an email at that mofi@health.mo.gov, and I can look up your profile for you.
Our next question is, does the risk analysis have to be completed within the 90-day measurement period chosen or just within the MU program year?
It can be within the program year.
If program year 2016 is a full year, how will anyone start entering numbers in July 2016? Am I misunderstanding?
No, you're not. I was thinking about that when I was going through the slides. The only people who would be able to are people who are testing to AIU and aren't therefore entering meaningful use data. So probably we'll have to look at the grace period and make it longer in 2016 for all the meaningful use attestations. We're still at about 30% of the attestations that we get are AIU. So we probably still will open it earlier so that those that want to do the AIU can do it earlier. But it's a good point that the meaningful use attestations will be coming in they'll be coming in 2017. So that means we'll have a different extended grace period for 2016 as well.
Our next question is, the Medicare deadline for eligible EPs is March 11th, and the SLR doesn't open by the deadline. Will the EPs be penalized for waiting to attest for Medicaid on the SLR?
No, there's no penalty associated with the Medicaid attestation. So attestations that come in through Medicaid in the fall of every year, every state provides CMS with a list of all the and identifiers of all the attestations that have been received for meaningful use, and CMS uses that list to as the basis for identifying who is subject to the penalty and who is not. Our program has never been completely over at the same date that the Medicare program is. So, but the information is exchanged late in the year, so everyone, and it can be updated anytime. So anyone that has submitted an attestation for meaningful use is identified to CMS in the fall of every year, and that's what prevents them from being subject to penalties.
What is meant by reports created by EHR system? In the past, crystal reports were used. Is this still permissible?
I'm not sure what Crystal reports refer to. So the meaningful use summary reports are every certified system has the capability to generate those, and usually there's a way to do that that is identified by the vendor. So if we need to, we can take this offline and you can send us the details of what you've submitted in the past. I don't know how that might be different from being generated by the EHR system.
Crystal Reports is a report writer, like a standalone report writer. So that's probably definitely one they want to hook up with you on.
Yeah, because that's not my understanding, is that they need to be generated from the certified system.
Yeah.
And I would have to do some research if there's some exceptions to that from CMS's standpoint.
Does the summary report from the EHR need to have been run within the 2015 timeframe, or can this report be generated later?
It can be generated later as long as your system can do that. It just has to reflect the 90-day period during 2015. So if you haven't run those reports yet, but you picked October through December, January 15, and you run your reports to reflect that data, then that's fine.
Okay, our next question there. We've got a fairly long list, just letting everyone know. If reporting period is full year in 2016, how can program year 2016 SLR be open in July of 2016? Wouldn't everyone have to wait until at least January 1st, 2017 to report for program year 2016?
Okay, I think that's the same question we had earlier. So you're correct that it can be open so that people could attest for their first year, but the people that are doing meaningful use attestations will be coming in 2017 to do that.
Exactly. Our next question, if we are working with the public health agency in Kansas, as we are located in Kansas, what type of documentation do we need to support active reporting? If the specialized registry is infectious disease, what type of documentation do we need to show we do not treat or diagnose those conditions?
Well, if they're reporting to the public health entity in Kansas, for one thing, they'd have to be registered, and we'd have to have evidence of that. I haven't talked to anybody in Kansas, but we may want to get in touch with the Kansas Public Health Agency to see what kind of documentation they support, because of course they have similar requirements to us. So we could accept documentation from Kansas if they're regarding reporting and or exceptions. We can recognize that, but you would have to have some documentation. So probably the best thing to do is to send in writing to us what your questions are to Brenna, and we could have some time to check it out.
I think, that sounds like the best plan. From my perspective, if you have locations in Missouri, sometimes we have people that have the pilot locations in Kansas, but they have alternates in Missouri. We can give you documentation for those. But for entities that are completely located in Kansas, I don't think our documentation is going to be able to extend to you unless you report to us.
Right, but we would still need documentation from the public health agency that you are reporting to. So I think you need to send the information to Brenna, and if you've got something already from the Kansas Public Health Agency, you can send that too so that we can see what that is. That'd be great.
Okay, our next question. Do you have to download an MU summary from the site, or can we just attach one?
We're just asking for it to be attached.
Are there any websites available where I can access measures required by the family dentists?
I am not aware of any sites that specify measures for dentists, but we could check into that. The measures for meaningful use are what's listed. I don't think there's a separate set of measures. Now, for the clinical quality measures, there may be some subset that is more applicable to dentists than others, although mostly all I've ever heard referenced is an adult, a recommended adult set and a recommended pediatric set. I don't think I am aware of any recommended set for dentists.
In relation to the public health measures, a dentist would probably not be eligible to report to any of our available registries, so you could contact me for the exclusions in this case.
Diana, you may have hit this one. I'm going to repeat it just in case. Do new providers still have the ability to do a 90-day option in program year 2016 instead of a full year?
So in program year 2015, if you're attesting to meaningful use, everybody has the option to do 90-day reporting period. Everyone who's attesting, whether they're AIU or MU, is using a 90-day eligibility period, and that's true every year. So if you're attesting for program year 2015 and you've never attested before, you'll be doing an AIU attestation and you won't be required to submit any meaningful use measures. And if I didn't cover what option you were thinking of, you can send us an email.
Okay, our next question. If we submit a hardship exception for program year 2015, do we still need to submit meaningful use data to SLR if we know that we won't meet the program year 2015?
I don't think that's possible. If the meaningful use data that you have don't meet meaningful use, then you wouldn't be able to submit an attestation. So there's no requirement that if you're submitting a hardship exception for 2015 that you would also attempt a meaningful use attestation.
For general pediatricians, other than the immunization registry, on a practical level, what other public health registries are available to report?
This is a question that comes up a lot. Most EPs are only going to be eligible for the immunization registry since they administer them. The syndromic surveillance is only available for EPs that practice at urgent care clinics. And if you don't practice in urgent care like most EPs, you would get an exclusion for that one from me in an email. And then the only other registry we have for EPs is the cancer registry. And that's available to EPs that directly treat cancer cases. If that's not you, again, you'd have to get another exclusion from me. And then there is the option for another outside specialized registry for you to meet that measure. To do that, you'd have to look into, a specialty society. They're not administered by the state, so I can't be your expert on that, but I can get you the documentation for immunizations and the exclusion.
We have a new provider that will be attesting for program year 2016. Will this provider need a 90-day reporting period of the measures? If so, the SLR will be able to accept it by October 6, 2016 to avoid Medicare penalties and receive the Medicaid incentive payments.
So, yes, a new provider, new to meaningful use, would have a 90-day reporting period. The penalties, so the normal process is the report that we send in for 2016. If you attest in 2016, you'll avoid the penalty in 2018. And given the changes in reporting requirements and the difference between a year one, I probably need to confirm that, but I believe that's true, that if it's your first year, you'll still get a 90-day reporting period if it's your first year time for meaningful use. Let me clarify that.
Our next question, the Excel DCN patient volume report generated by our EHR has to be modified because it drops any initial zeros in the DCN, creating invalid DCNs. Does this cause any problems with you?
Somebody will have to send an email about that, and we'll send it to the person who does our volume checking. I've never heard of that, so I don't know if that creates a problem. I would think it would. So I think we need to do some checking on that.
Our next question, 2015 was the last year you could change EHR incentive program registration from Medicaid to Medicare. If a provider has it registered as Medicaid for past years, but they don't meet the 30% eligibility now, how can Medicare numbers be entered for those providers? Does the registration need to be changed? Is it possible?
No, the registration doesn't need to be changed. Medicare there's no special box you check to say that you're doing this alternate attestation method. Just go into the system. It'll ask you for identifiers. All the registrations are done. Initial registrations are done at CMS. So when you go into the system, it will know that you are a Medicaid provider. So the CMS system is set up now to accept meaningful use attestations from a Medicaid provider, which has not been true in the past. And as I understand it, you just go into the system and the CMS RNA system and enter the information that's requested on the screens for attestation, and it will identify you as a Medicaid provider. It will recognize you and accept the attestation. And I have talked to some people who have successfully done this. So.
We have received notification from CMS on 2 providers that are incurring the Medicare 2% penalty for 2016 Part B payments, simply because we attested AIU for them in 2014 and couldn't attest them to a 90-day reporting period in 2015 because the SLR was unavailable. Ultimately, this was forced us to stop attesting AIU in the first year. Do you agree with this?
Well, it's correct that if the initial attestation in 2014 was AIU, then would be subject to the penalty in 2016 and took the hardship exception and had some vendor issues. So you're not obligated if you have providers and you have a system and you can attest to meaningful use the first year, then you can do that in the Medicaid system. So in 2015, the attestations should avoid the penalty in 2017, the way the timing is designed. So I'll take a look at this question too, Laura,
Okay.
To see if there's anything else relevant.
Great. We did have one comment that the CDC has surveys which will also count as a specialized registry, which are free for all providers. Somebody did let us know that based on that. Okay, Lori Johnson, you have your hand raised out there. I'm going to unmute you now, and if you want to go ahead and ask Diana your question, go right ahead.
A Medicaid provider who didn't meet the Medicaid volume threshold, and they go ahead and they attest through the Medicare registration and attestation system, the alternate attestation to avoid the penalty. And then in a subsequent program year, so we did that for a provider in 15, if in program year 16, they now meet the Medicaid threshold, are they allowed to go back and attest through Medicaid, or should they just always attest in the Medicare through that alternate attestation method?
No, they would come. The alternate attestation method doesn't change them to Medicare. It just gives you the option to submit meaningful use data so you can avoid the penalty, because there's no way you can attest in our system if you can't meet the eligibility threshold. But in effect, you're not going to get that EP is not going to get paid, and it's going to be the same as if they skipped a year. No, you should not go back every year. If they can meet the volume, they should come back into the state system next year, and then they will resume. Like it'll be as though they skipped a year, so they'll resume their payment schedule in Medicaid as though they didn't do anything. Yeah.
All right, great, thank you.
In regards to the patient electronic access, if the 50% volume is not met, what do you do? We are in an area where a large portion of our patients don't have or care to provide email addresses for this.
We'll have to look at the specification sheets for that measure. I can't recall what the detailed information is on that measure, but usually there's in the past there's been recognition of broadband issues that may not be exactly what's being asked, but we'll take a look at that and respond in writing.
You guys have been wonderful participants today, and thank you, Diana and team, for being available to answer all the questions.
Thank you, Laura. We'll do some follow-up and get some more information out there.
Sounds good. Thanks, everybody. Have a great day.